All right, so to my left. All right, we're going to start our data wave panel now. All right, so next to me we have Aaron Black, Chief Data Officer for Inova Translational Medicine Institute. In the middle we have Colonel John Scott, Data Manager for the Defense Health Agency. And then to my far left, oh, I'm sorry, wasn't even looking up before I said this, yes. Okay, Aaron Black is to my furthest left. In the middle is Colonel John Scott, and to my immediate left, we have Tony Jones, co-founder and CEO of Frontive. My apologies. All right, so let's go down the line real quick and just give a brief description of what it is you do and your organization or agency. Start with you. Yeah.
So I'll do a quick start. So Frontive is what we've developed is a smart personal health assistant. So to make a very long story short, we use smart speakers like Amazon Echo, combine that with different cognitive technologies, combine that with people's personal health data to really make it easier for patients and families to manage the day-to-day complexity associated with complex health.
All right, Colonel?
John Scott, Defense Health Agency. I've got the nebulous title of data manager. I'm specifically not a chief data officer, so that people don't think I know more about the actual IT than I do. I'm sort of the head cheerleader for the people who are constructing our integrated data platform. My job is in the plans and strategy directorate, and I try to make connections, bring people together, bring all our data stakeholders to the same table so that we can find synergy and build out what ought to be one of the most powerful clinical data sets in the world, especially if we can collaborate with our partners in the Veterans Administration.
So again, Aaron Black, I work for Inova, so it's an integrated health system in Northern Virginia. My role is kind of a hybrid, so we do a lot of large-scale genomic research, and so our team support the full data lifecycle behind that, the collection of patients within our EMRs, the collection of blood specimens and biobanking, as well as the generation of genomic data, and then making that available to our researchers and scientists, not only within Inova, but across really the world now. We have hybrid architecture that allows us to do that. And then on the other side of that, we also support clinical testing within the health system. So the health system has rolled out a lot of pharmacogenomic testing, and our teams help streamline that process, do a lot of quality control, and then return those results back to our patients.
All right, great, thank you. Colonel, I wanted to start by asking you how DHA is using predictive analytics in its enterprise data warehouse, to make smart, to make real clinical decision tools.
Yeah, so the first step is, our AI panel and others have pointed out, to being able to make really good use of machine learning is to get that integrated data platform. So we're still in the stage of, I think, bringing all of the resources to a common table so that data platform will be large enough. But some of the things that we should be able to apply predictive analytics to relatively soon are things like being able to predict who's likely to go through a medical board, right? To have a medical condition that prevents them from being able to stay in the services. Using things like the adjusted care groups that we've been able to apply to our data set already, we'll explore that. And if we can effectively collaborate with the VA, there's not a case control study you can imagine that we shouldn't be able to begin to apply what we have to help solve. We're storing all of our unstructured artifacts in an electronic filing cabinet that we can fetch. We expect to be able to bring language processing technology to that in the future, but we're still really at a foundational level there, where bits of innovation are happening across the MHS, and we're about to cross a threshold where we are able to apply that to really what is the enterprise data warehouse, as you mentioned.
And Tony, if you can quickly explain the Smart Personal Assistant for Health and how it collects data and how it's used.
Yeah, I don't want to take up all the time on the panel, but the thing I would say, and it's important to sort of think about just sort of where we're coming at it philosophically within the healthcare space. A lot of work that happens is focused on doctors, payers, hospitals, et cetera. at some point, as you make it easier for those people to do something, especially doctors, what that ends up doing is it translates into work that usually falls on the patient. And it usually falls on a patient and the family. And so if you imagine at some point that task management becomes somewhat overwhelming, whether you're doing it for yourself or you're trying to do it as a caregiver for somebody else in your family. So what we're doing is really saying, okay, given the data that's available, whether that data is in an EHR portal, whether it's in a retail pharmacy portal, how do you take that data and really make it more usable, make it easier for that patient and family to manage the task that the doctors have assigned to them? And getting on a little bit of what he was mentioning, the predictive part. We're not trying to predict disease or when you might be likely to come down with a certain condition. What we are trying to say is, how do you predict actions? How do you really think about, based on what I know about you, what are the actions you need to start thinking about or doing, and directing that back toward the healthcare system for you?
Wonderful, thank you. And Aaron, so the Translational Medicine Institute, you're leading a group that's building a data analytics infrastructure to support Inova Health Systems genomic analysis. Can you talk a little bit what goes into building an infrastructure like this and what it means for the future of predictive analytics in medicine?
I will say it takes a lot of craziness, a lot of hair loss, and a great team. I have 2 team members here that you need a great team to build something like that. And you also have to have imagination, and you also have to ask a lot of questions. So even up here, some of the stuff that you're talking about, like, we love to be part of that. I mean, as a patient myself, and in the healthcare, we know that a lot of this is focused on that interaction between the patient and whoever's providing healthcare at that point. And so what we're trying to do is leverage a very flexible architecture to be able to apply these things, because a lot of the role that we have is a kind of a translator. Right? We want to translate what the doctors, the physicians, the patients want into something actionable that they can do. And on the biomedical level, which is where we focused a lot of our time, it's sequencing people. It's finding results. It's actually putting something very complicated into a package that someone can, within seconds, know I either give a drug or I don't, even though the sophistication to get there was immense. And to implement that into a health system is a lot of people, not technology even. It's genetic counselors. It's training physicians. It's patients not overreacting to the results they get. So a lot of what we're trying to do is be that bridge, a little bit of a sanity, because there's also expectations that hit a health system who brands themselves precision medicine. Mm-hmm. What does that really mean? And we're trying to be the bridge to make sure that that happens.
Right, and when we talked earlier, you mentioned that operationalizing a health system takes more than just analytics and the technical side. Yes. Can you talk about the education and the training?
Well, I think that was the biggest lessons learned we had. Was it was a great test. We thought the results would help our health system, but just putting that into an electronic health record, nobody's going to use it. Like, they didn't know it existed. They weren't sure how to order it. A lot of these things aren't reimbursed yet. So part of our role is also, making sure that we're tracking every single touch point, from when a patient comes in, do they ask for it? How fast can we get it through the banking? How fast can we get the results? Because we want to show that this is a valuable test for our health system. So that all has to be thought about. The EMR integrations, working with companies that are not physically located in the DC area that can do knowledge bases and build reports with us interactively. Working with the physicians on what they like to see versus what we think they like to see, and then iterating through that in some cycle and some sanity. And just really also promoting this up the chain. So how do you get an executive to buy in? We did this in a pilot. How do you move it to the next level? How do you sustain that momentum for the next test when you have great ideas that are coming into the system? How do we leverage the infrastructure that we've already built?
And Colonel, considering the size and scope of DoD and the amount of data it collects, how are you scaling your efforts to partner with other agencies like VA and NIH?
scaling our efforts. You start to cross right away my depth of understanding of how the IT works, because it's still sort of magical. I rely rely a lot on my colleagues, and they use words like Hadoop and things, and to talk about the enterprise data warehouse that's going to be able to do that. But one of the things, and I'll channel my colleague David Carnahan for a second, is we've got to be able to make our enterprise data warehouse cloud accessible, right? We have to be able to participate with our partner agencies in cloud computing, and we're looking at how to do that, specifically with the VA to solve problems like joint registries. And we have a project that's a few years in the more pedantic aspects of just mapping the data to a common data model, and then still doing it by, as Paul Tibbets said, an ETL process, but with the common model and with what we expect to be able to do as we get that allowed to go up to the cloud. Ideally, we would do the virtual registry in cloud computing and do that with the VA. And when there are multiple federal agency projects, like there's a project called Apollo that is DoD, VA, NCI, that's looking at proteomics and genomics, when we can take that set of patients who is part of that clinical trial and establish that all three federal agencies have a need to know, so to speak, a HIPAA-covered use to be able to apply to that, and we can consider all that data that's acquired in the clinical trial as part of those person's health record, I think HIPAA becomes more freeing than constraining. And so we're addressing sort of the policy issue that was mentioned earlier to the challenge of that. So. And that's where I've spent more of my time. What are the policy constraints to being able to share data for that type of activity? And then I'm expecting my colleagues on the technical side to work their magic and make that possible.
Do you face, Tony, any implications with the tool that you provide? Any data collection implications or privacy concerns, consumer concerns?
No.
Okay.
No, I'm kidding.
All right, next question.
Yeah, just a couple. Again, I think it's been said by a number of people on some of the earlier panels. You can't approach privacy and security with a checklist. And I think too often the assumption is, okay, what is the bare minimum we have to do to meet a regulation or meet a certain standard? I take a slightly different approach. Yes, you need to do the part where you have processes and you have technology to support your efforts around privacy and security. Fundamentally, I think it's a leadership issue. You set the tone as a leader of an organization as to what matters. You tell everybody in your organization, these are the things that matter to us, and these are the behaviors we're going to reward, and these are the ones we're going to punish. And everything else is really an enabler to make that happen. So coming up with processes around security and around privacy, if you now delegate that to somebody low in the organization who really doesn't have a seat at the leadership table, you're pretty much guaranteed you're going to have a problem. And so I think, again, the technology is critical, but the flip side of that is organizationally, you've got to make it a priority.
Aaron, do you face any similar challenges creating this data infrastructure in genomics analysis?
Say that again?
Do you face any similar challenges?
Yeah, I think one of the things we do is we have a very nice informed consent for our research individuals, and so we have one study where we consent mothers. It's between 16 and 24 weeks of pregnancy, and right there they get a brochure. They get promised a $25 gift card if they continue to give us longitudinal information about them, and our rates of consent when we ask are pretty high, pretty standard, until there's a data breach of someone else, right? So when Target got hit, all of a sudden our consent rates went way down. And then all of a sudden the confidence goes back up, and it seems to be a transient thing. But to Tony's point, this is something that has to be embedded in the organization. And healthcare actually is very defensive, right? Especially now. They're very much actually very data-centric, and our IT departments are very conscious of this. So for us, we have to, again, be that translator between the two to say, okay, we want to understand where you're coming from, but this data has to flow out in order for it to be effective. How do we find some partnerships that can allow us to do that and kind of embrace that symbiotic relationship between an offensive and a defensive stance?
Well, and ultimately, what do you hope all this data analytics leads to, and what do you hope to wrap around it all to make better clinical decisions?
Well, again, I from a personal story, some of this is not all that sophisticated. Some of this is just, can I exchange data at the lowest level? And so for me as a consumer of healthcare and being a kind of a double agent where I'm inside a healthcare system, it's really trying to get to the fundamentals. Like, we're trying to shoot three-pointers a lot. We're trying to dunk a basketball when we can't dribble yet. And it's very uneven. So the thing that I look for is trying to apply technologies that have the biggest impact. Not the biggest brand name or the biggest buzzword, but what's going to make a difference in the day-to-day lives of the individuals who are coming to us, because they're going to keep on coming to us if they get the right experience.
And in the government, Colonel, what are your main challenges?
Just being in
with data,
with
data collection.
We have a healthy tension, I would say, between those of us who work at the headquarters and are trying to have standardization so that we can recognize variability, et cetera, and achieve efficiency, and those who are our centers of innovation. And I think a huge challenge we've had in the DoD is figuring out how to draw the lines so that our innovators can, color within those lines and then make very nice pictures. We're going to have a forcing function now. We're acquiring a new electronic health record that'll have with it its own enterprise data warehouse. Doing that has made us look very hard at all of our workflows and standardize them, and we're finding our first challenges at getting people to accept that new reality that we have a COTS product in the Pacific Northwest. So where was I going with that? We're going to kind of have the cards in our hands at the headquarters level in terms of the data management. So we're going to be able to set the rules with data management and then have our innovators get access to that, so that the things that you're both talking about, as long as we standardize the definitions of what we want to measure, we don't care whether they make it blue or yellow at the level that the decision maker wants it. So I think we'll allow, and others spoke to that earlier today, we'll allow innovation at the data display, and as long as we have people on a common platform, which is our goal, then we can take whatever is the ideas that do best and immediately promulgate that across the rest of our organization. So that this dynamic tension between innovation and standardization, I'd say, is one of our biggest challenges. And I think I keep saying this, I've been saying it for years, we're on the verge of doing great things because we're getting better at that.
Are you doing predictive analytics yet, or?
We are in pockets, right? So we're applying those ACGs to people of emerging risk, and our medical management people are beginning to be able to use that to focus intervention on people who are emerging higher risk. Taking that beyond what's proved out elsewhere and seeing how it applies to some of our specific readiness questions. Is this person going to succeed in a deployment? Can we use some of that same technology and apply it there? That's what we've really just been challenged to do based on the executive order to do things better. And one of the aspects of our plan to that is to begin to apply predictive analytics to the data set we ought to have, and looking specifically at things that have to do with readiness, but also looking at what can we find predictors of negative behavioral health outcomes for veterans? Can we study our population that's just transitioned? A lot of focus right now within the department and with the VA is at trying to look at that and figure out how to apply this integrated data platform we're building for so many other reasons to that problem. And I think we're going to, in a year or two, I think we're going to have some things to talk about.
And as that advances, how does that make your job regulating data and governance harder? So
the governance problem is just telling everybody who you need to know. I met just today several people, one in our own Department of Defense. Like, we need to talk. The science that you can bring to the table, we need to bring that to our table. We're so big and distributed that's often the biggest challenge. Just getting us to the common table. And again, the data governance is one way that we will do that. So we're It seems like every other day I make another governance body, much to the chagrin of some of our executives who think there's too many already. But we've just formed one that'll be a DoD-VA joint registries team, and it'll help inform our data migration planning. So I create these governance bodies, and people hate it because there's too many of them. But that's how we're going to achieve the real value of what we in the VA can bring to the table.
All right, and getting the cue that we need to. Do we have time for Q&A? No time for Q&A. Well, please give our wonderful panel a round of applause. Sorry to have to cut it short.